absolutely. The key thing is to not get locked into debating that. Yeah.
Quick question about that. I was curious when you decide to use either a coping script with the client or more of an imaginal exposure script.
Yeah.
So it sounds like I'm actually reading it wrong, I make a mistake, I'm going to miss something when my supervisor asks me a question. Which route you choose or if you use both?
So the question was, when might you use a coping script versus imaginal exposure type thing? You can use both. I would just use them differently. Imagine exposure. The exposure is in imagination. Whereas the coping scripts are used with external or other triggers. So you're using it to deal with the trigger of reading or the trigger of, whereas imaginal exposure, you're just sitting thinking about often your worst fear. You're in the situation, like we talked about earlier, yeah, where he's getting criticized. And so in the imaginal exposure, you're just listening to the imaginal exposure. Whereas coping scripts are used to facilitate coping with other triggers, like the ERP, mainly who we're talking about. Yeah. Okay, so this was his coping script. And again, the difference is if you're trying to do homework, you're trying to get through your homework and blah, blah, you're not going to pause and listen to a coping script. So the goal of using homework for exposure is to trigger yourself. And then as an opportunity to learn how to deal with being triggered in a different way. It's not about getting your homework done. Presumably, if you do this enough, you'll be better at your homework. But the idea of processing, learning, what happens when I feel in doubt? Can I learn to get past that? Does something catastrophic really occur? If I ignore that feeling of doubt and move forward anyway, rather than giving into the doubt and having to create this illusion of certainty that you are safe. So, and here, we would say the instructions for outside of your formal ERP, so I just want to make sure, when I talk about ERP, I'm talking about you plan it like 4 o'clock every day. I'm going to sit down and do my ERP practice. That's planned exposure. Outside of that, the instructions might be a little bit different. When I feel the urge to reread, I will resist the urge and continue reading the paragraph without looking back. If I slip and reread, I will try to refocus on reading the next line without additional rereading. So just trying to get it done, get through the day. You may not have, it may not be convenient for you to always stop, get a coping script, try to process, but just do the best you can to get the reading done. And because when you're in ERP, we really want you to have fidelity. We want you to really try to follow these instructions so that you create the conditions in which your brain can learn. Writing papers. As you might imagine, low challenge, a paper about a similar kind of hierarchy, things that are relevant academically, then things that are a little more relevant, then things that are really relevant. So for writing a paper, we did some skills training, how to do it. And again, a lot of our folks are doing mental editing where they're trying to do all of this at once, all of these steps, and have it come out as this finished product, which of course immobilizes them. So you select the subject, you research the subject and take notes, then you write an outline, you write a first draft, second draft, third draft, and submit the paper. And we really try, we give them 3 drafts. We're really trying to give them an opportunity for reasonable editing, and then really to turn it in, even if they feel not right. Remember now, we may start with a paper that's totally on a bogus subject, just to start practicing RP. So response prevention for this, for each step. I think what I'll do, rather than read all of these, is, can everybody read this? Or I don't know if you can read it on the handout or not. Is it readable on the handout? Yeah, okay. So for step 1, we will have rules, and don't get too caught in how many minutes, but we try to have a timeline. For this period of time, this will be selecting the subject. And here's what you may do or may not do, but at the end of that time, you're going to select a subject, and you have to have some subject at the end of that time period. And the goal is to try to, I want therapists for you to be able to see these as examples, not like protocols. What you're trying to do is figure out ways to set rules that are clear enough that they can follow it, and they help them resist the compulsions. You may discover much better ways to do it than the ways that I present here. But just to be clear that there's a reason there are 3 letters in ERP. Right? There's 3 letters. I don't know if you know that. There's 3. You're going to go home and go, what'd you learn today? There's 3 letters in ERP. I had no idea. There's a reason why there's 3. Because the last 2 are the ones that often are not paid attention to enough. So you're getting the E, but you're undoing it all because there's not good RP. And so you expose yourself. You know, again, I would tell the joke about the elephant gun and the gentleman with an elephant gun, and he just coincidentally happened to live in Newark, New Jersey. I couldn't believe it. And he was in his backyard with an elephant gun, and the next door neighbor looked over the fence and said, hey man, what are you doing with an elephant gun in Newark? And he said, well, I'm keeping the elephants away. And he said, well, there are no elephants in Newark. And he said, see how good it works? Okay, so the elephant gun is our patient's compulsions. And that guy's never going to learn that there are no elephants if he doesn't put the gun away. As long as he believes it's the gun that's keeping the elephants away, he will never learn what his brain needs to learn, which is safety in the absence of the elephant gun. At least safety from an elephant. There are enough things to be scared of in our country, but elephants is not one of them. Response prevention 2, researching the subject. And again, you'll see that it's giving very detailed instructions about the rules they're supposed to follow. For how many minutes, hours, depending on the task that you have to research the subject, and then giving guidelines to help you keep you moving so you don't get stuck. Let's see how we do it. What time do we stop?
5 minutes to 2.
5 minutes to 2? Oh, okay, so we're all right. So now we're getting into writing an outline. Organize and title the sections of the paper. And we've always put it in first person, not you will. It's guidelines for Jack. I will work on step A of my outline for X minutes or hours. During this step, I will focus solely on naming the sections of my paper and placing them in the preferred order. When I feel the urge to work on any other step of the paper or to make things perfect in any way, I will redirect my attention to the task of the step. So encouraging them to stay on that task, because that's a very common thing that perfectionists will do to avoid. They'll move to another step because they don't want to make decisions about this step. So as an avoidance, they'll move to another step. It's like a person with a hoarding problem, and they go into one room and they get all anxious, and they go to the next room and they get all anxious, and they never start. They just move from room to room as an avoidance of getting started. I organize them within the time limit. I will then listen to my coping script. So again, the coping script is like to prevent post-triggering compulsions. Figuring out, reassurance seeking, mental editing. So because when you do, time limits up, bang, here's my subject. You're going to now want to second guess. You're going to do it. So you go into the coping script to try to interfere with those post-triggering compulsions. That's part of the process. Then you do an outline. The objective is to select information from research notes and place them under the appropriate section heading. So once again, we have the same kind of thing where you're giving the really clear instructions for how to write the outline, how to do it. Writing the draft, the first draft. So from the outline, you start at the top and you start writing free-form sentences following the outline, not skipping, and not making them perfect. It's really hard. Just in this draft, we expect it to look horrible. Just get the ideas out of your head, get them articulated, even though they're not perfect, and get them on there. That's just draft 1. And then you listen to the coping script, and you don't stop until you're sure you're going to move on without going back and doing the compulsions. This is draft number 2. Again, it's a similar kind of thing where you're trying to give them instructions to follow so they don't go back and compulse. And draft 3, similar thing. So I don't want to bore you with just reading this. You can read it yourself, but you get the idea. So that's how the exposures would work. And Jack would do these exposures, some in our office, and then some on his own, scheduled during the week. And I want to be clear, once again, this was not scheduled, it was not to replace his homework. It was a separate thing from him doing his homework. In fact, there was a period of time where he took a leave so he could really focus on the therapy, and we didn't have the issue of him having to keep up with his schoolwork. So his parents were in Chicago, so we did phone sessions with the parents, helping them understand what we were doing, why we were doing it, and then we agreed on a reassurance-seeking protocol where they were to say to Jack that they had confidence in his ability to make decisions himself, and that the response from both parents was supposed to be, you and Dr. Pollard have asked me not to answer those kinds of questions, so unless the policy has changed, we're not going to answer it. And they did pretty good at that. Not everybody does. Sometimes we have to work on that more with families, but they did pretty good. Or the patient tries to talk them out of it. We have a reassurance affirmation that we do with folks who have a lot of reassurance providers, because you know some folks have lots of reassurance providers, like lots. Yes, you have a question.
Yeah, just a question about, you're talking about a student that was out of college and his parents were away and took a leave of absence and was working on this. What do you find about the living situation of those kids? Because what if a kid is like so embarrassed about being in a dorm or being around others and doesn't want to tell people that they're going through this? And how have you experienced that? Because that's a big thing, I think, in some areas.
You mean they don't want to tell the people that they're in treatment, or they don't want to tell them they have a problem?
That they're in treatment, that they have a problem, something like that, and they're sort of maybe saying, okay, I'm going to go, but they're living in, say, a dorm or something like that. There's kids around them, and you know, you're saying you have to do your ERP or something like this, and do it at 4 o'clock, and somebody's sort of sitting there going, what are you doing?
Well, we try to have them find a private place if they can. We're fine with them not telling people. You know, honesty is not always the best policy, at least in the short run. But if they can and they're willing to tell people, it's better because it takes the pressure off trying to cover it up. But I don't want them not doing it because they're ashamed either. So yeah, we try to find a place where they can do it in private and respect their privacy as much as we can. So yeah, but that does become an issue sometimes. Yeah?
I love the detail and the response prevention little vignettes that you provided. How do you encourage generalization to other tasks, or like in the future when they're on their own? Do they actually sit down and write out these types of scripts as well, or what do you do with that?
Well, a lot of it depends on how much generalization they've gotten from whatever they've done so far. We tell them, and this is an important point, we tell them that even if you start to be able to be more fluid on a range of tasks, you should know that this is always going to be probably a vulnerability. And that if you get into new situations, and if your brain says, wait a minute, I don't know if uncertainty is safe here, because we haven't tested this yet, then they need to be aware, they may need to do some work, again, in that area. And not to expect that because this range of tasks they've been able to do better, that they necessarily it'll always generalize to other situations because it may not. So they need to be prepared for that. Yeah, it's a very good question. Okay. Yes?
Clarification. You mentioned about safety. My understanding of ERP is that we have to take them away from safety behaviors. So could you clarify what exactly you mean by safety?
By safety behaviors?
Yes.
Okay, this is a very good question. So just to frame her question, that you have heard people talk about getting rid of safety behaviors during exposure. But that's what compulsions are, they're safety behaviors. It's just that compulsions, I use the term secondary avoidance versus primary avoidance. They're different terms, but primary avoidance is avoiding it altogether, and secondary avoidance is if I can't avoid it, then I'm going to do this to create a feeling of safety. And so a lot of things are in that. Compulsions, superstitious behaviors, all sorts of things. The word safety behaviors emerged in the field of anxiety disorders to describe a bunch of different behaviors beyond what are classically called compulsions. Compulsions have kind of been historically identified with OCD, but they are safety behaviors. And then all these other safety behaviors have been identified from people looking at social anxiety disorder and panic disorder. So for example, if I have a panic disorder and I carry Xanax in my pocket everywhere I go, just in case, that's a safety behavior. We can call it a compulsion too. And the reason that it interferes with learning is that I don't learn that I'm safe even if I panic. I don't learn that I'm safe. I learn that I'm safe as long as I have my Xanax. And that's why you hear therapists rant and rave about getting rid of safety behaviors, because that promotes generalization and learning that needs to take place for a person to have a different feeling when they approach something. Otherwise, your attribution is always on the elephant gun instead of the absence of elephants. And compulsions are just one type of safety behavior. That's all. Yes?
Do you utilize compulsion monitoring in your treatment?
So what do you mean by that? I think I know, but could you explain what you're meaning?
Well, just to get a sense of how the individual is doing with regards to following through on the response prevention? Like,
Yes.
how do you go about that?
Absolutely, yeah. So we might have a form that says, this is what I plan to do, Monday, Tuesday, Thursday, 4 o'clock. It says when, and then what. And it might say, I'm going to read an article and write a short paper, and without rereading it. And then the second half says what I actually did, and like, did I do it when I said I was going to do it, and then what did I actually do? So they might say, I read it, but I did slip twice into an exposure, or whatever. Yeah. So yeah, we would monitor that. And for the most part, folks with OCD are pretty honest, almost to a fault. Sometimes they're confessing things that I don't want to hear about. I don't care if you had a bad word yesterday. I don't care. Okay. So, so at any rate, the family is really important to get on board and get them following the reassurance. And if they can't do complete reassurance seeking, if they can't totally do it, we phase it out. Try to have so many reassurances a day and then drop it if they can't go on complete response prevention for reassurance. The school, we wrote a letter to allow him to retake one of his clinicals and remove the F from it because he had flunked. He was so nervous that he couldn't process any information. But one of the things that we would do is that the coping script sometimes can be integrated into real-life triggers So sometimes before he'd do a clinical, if he was getting prepared and he was finding himself nervous, we'd have him take the coping script maybe in the restroom, listen to it in a stall and where he has privacy, and kind of prepare himself for the clinical, even though it wasn't formally a planned exposure. So his treatment was 14 months, and so I point this out for those of you who think you're supposed to do all this in 12 weeks or always, whatever. And it was 14 weeks on and off. It wasn't, 14 months, excuse me. It wasn't, he was sporadic in coming at first. That was during that phase where he was coming in and saying, I don't think it's a problem. And then he would be back because it was a problem. And so there was a lot of that 14 months was a number of months where he really wasn't engaged. We were just kind of trying to get him to the point where he would engage. And then we had to work on his driving phobia, so he'd get there more consistently. We did meet all three of his goals, and you see this caution about maintenance, because that question about generalization is really, really important. That folks need to understand that they're vulnerable, even the things they've already exposed themselves to. If they slip and start doing compulsions again, they can go backwards. So they need to know that they're more kind of like a lifelong vulnerability, even though you can get tremendously better and function really well. You always kind of want to know your vulnerability. Much like an alcoholic needs to know that, well, maybe I shouldn't drink. Maybe I'm vulnerable to that under times of stress or whatever. He did graduate, and at the end of this time, he was doing his internship. He did remarkably well. But again, it took a while, some ups and downs, some hanging in there, and going through the pros and cons. I think I'll stop there and open it up to questions, because that's the end of Jack's story. Yeah.
What might you do differently when the person may have like OCPD comorbidity and they're more entrenched in terms of the egosyntonic nature of their beliefs,
Right.
and their rigidity is more negatively impacting their social world?
Well, I would tell them they have OCPD, and usually that does it. They say, oh my God, you're right. I need to listen to you. So the question was, what if you get somebody who's got OCPD and they're really, their beliefs, they really intellectually, they have what we call overvalued ideation. They really believe these things intensely. There's a lot of perfectionists can have, like any type of OCD, you can have people say, I know this is probably not right, but I can't help it, that's how I feel, but I know it's not logical, or I know there's something wrong with it. But then there's folks who say, no, don't tell me. You guys are all irresponsible. And what is wrong with you guys? This is, that's why you can't ever use science as your main argument, especially with contamination, right? Because they can say, well, science hasn't always been right. Oh, man, you're right. No, never mind. All right, let me get another argument. Okay. So if we were to say that I think the implication for OCPD that you're meaning is the strength of the belief and its resistance to treatment. So then it begs the question, why are they there? If they believe so strongly. And there are at least two explanations. One is the family's brought them there, and they don't have any investment in it. In which case, if our best assessment was this person's just not open to it, then we would work with the family to try to help them deal with this family member. If it's the explanation is that they kind of know something's wrong, but they don't like the solution that's implied by your therapy, if you know what I mean. See, some people want come to us with the hope that we're going to make them more efficient compulsors. Yeah, I just need to get a little better at it so I can get out of the house quicker. And so then when you start talking about stopping it, that RP thing, what? You want me to stop that? Do you want me to risk my whole career? Yeah, so one of the questions that I ask, and it's not a perfect discriminator, but is if you had a choice and you really had to choose between having the career that you're perfectionistic about, whatever it is, but being miserable. You're successful in your career, reasonably so, but you're miserable. Or you're happy, but you're in a different career. Which would you pick? You have to pick one. That's a tough one. If they pick option one, that's usually a pretty strong sign that they're overvaluing this. So my approach to them would be this. Look, I have no ability to help you as long as you keep your stance on this exactly the way it is. I'm not saying you have to completely change everything, because there's a lot of good stuff in your thinking. You know, you want to do a good job. You're conscientious. I don't want you to stop doing that stuff. But tweaking these beliefs a little bit is going to be necessary if I had any chance to help you. So we got two options. One, you can fire me, which is perfectly okay, because I'm not going to try to go and treat your condition under your certain set of beliefs that you have right now. Or you can allow me to work with you for a while and see if we can't find a way to loosen up those beliefs a little bit. John Abramowitz, I think, who spoke here not too long ago, right? Yeah. He calls it tenderizing the cognitions. He and I have a very strong theoretical debate. I call it marinating the cognitions. Very. Anyway, so that's kind of what I would do. And then if they're willing to, we would make, I'll say one more thing about this. We make a distinction between, and this is important, between what we would call felt beliefs and intellectual beliefs. So felt beliefs, we expect, and everybody got a sense of what I mean by that. Felt beliefs, we expect everybody to have maladaptive felt beliefs. But we do want them to have adaptive intellectual beliefs. In other words, I get it that I'm probably not going to get cancer by touching that chair. I just can't help it. That's what it feels like. Right? Okay, that person can be treated. You can go to ERP. But the person whose intellectual belief is high as well as the felt belief, then we frame it as, we don't have good luck with people whose intellectual beliefs are way high like that. So we might say, on a 0 to scale of 1 to 100, what's your level of conviction in this belief? With 100 being absolutely sure. So it's okay if your felt belief's 100, but if your intellectual belief's 100, we've got to find a way to bring that down. And do you want to work with me to see if we can? Because I don't have a way to help you otherwise. And I put it in their lap. And we see what happens. Sometimes they fire me. Sometimes they're willing to work on it. So. But do not do ERP with someone who has the intellectual and the felt beliefs at 100. You're just going to be miserable, and so will they. And you don't want to be miserable, because my saying, I always live by, a happy therapist is a happy patient. So, yes?
Could you talk a little bit about perfectionism in BDD and working to challenge the idea of necessary perfection in parent, just to get somebody even motivated?
Yeah, you said BDD, right?
BDD, yes.
Yeah. So there are certain diagnoses that you kind of like, now you don't want to generalize, right? But if you see BDD in the intake, so you automatically are thinking, okay, ERP is going to be a while. This is going to take a while to get them prepared.
Could you clarify what BDD is?
Oh, body dysmorphic disorder. I'm terribly sorry. That's right. Yeah. So that's where you have you feel like one or more of your body parts is ugly or hideous, way out of proportion to what other people would objectively observe and say. I have the opposite disorder, by the way. I have body euphoric disorder. I actually think I'm much better looking than I am. It's a different syndrome. It's not treatable. So I will answer your question. Pretty much the same thing. But we start with clarifying. It's useful in general to make sure the patients know clearly what you can do and what you can't do. And always being open to being fired. I realize that, you have every right to let me go, and that's fine. But here's the limit of what I can do. Here's what I can't do. I can't make you feel pretty. I can teach you how to learn despite feeling ugly. I can teach you how to live your life despite feeling ugly. There's a lot of ugly people out there. They function well. You don't. So I don't try to tell them they're pretty. You know that. Yeah, you don't get into it. Because same thing, right? Oh, you're good looking. That mole isn't very big. And of course they say, oh, you're right. I'm better now, thank you. So we get into your philosophy of life is to try to strive to feel pretty, or to feel handsome, or to feel whatever. And how's that working for you? Here's a different philosophy. But you need to know clearly, this is what I'm going to help you do. And I understand if you want to still pursue trying to feel pretty, and I'll always be here to come on back if that doesn't work for you. If it does, great. Call me, let me know. But something like that. And then if they're willing to work, then we work on the cognitive work of acceptance of, and part of that may be challenging beliefs about the importance, the disproportionate importance of physical beauty on their priority list and all of those things.
It sounds like you use inhibitory learning theory and more of just being comfortable with being uncomfortable versus a habituation.
Yes.
Do you also use inhibitory learning theory? I've heard you talk about maybe going up a hierarchy in order and doing assignments at a certain time of the day. Do you do more of the skipping around kind of stuff?
Yeah, except with so let me explain to what that question is. Man, we could spend 3 hours on that one. Okay, so let me see if I can do what in my generation we call the Reader's Digest version. There's a kind of research to showing that people can overcome fears without, remember I was talking about that hierarchy and how you need to go up it and blah, blah, blah. My reason to say that is not that I think you must go up a hierarchy, but because that's what will actually work most of the time. And if you want proof of that, then do ERP first day with a student and do schoolwork. And then you see how that works. So conceptually, inhibitory learning theory says to us that it's just as good and maybe